I want to talk to you about weakness of the lower extremity from functional stenosis, but I also want to thank CDI for allowing us to do the first pilot study using a standing MRI and evaluating the back, and then doing our next study, which is going to be evaluating disc to see if they will reduce in size, and looking at stenosis to see if we can measure stenosis and see if there's any soft tissue impingement around the nerve that creates weakness. The talk today cannot be done without a background of what we've already talked about. So I'm going to review this a little bit and then jump into the functional stenosis. We were really interested in the anatomy and to see if a foot could change the spine. So we used a standing MRI and the intersegmental angles here. And when we pronated the foot, there was increased lordosis on three of the four levels. We're also interested in the core because everyone talks about the core. So we kept the knee straight and then asked them to do a pelvic tilt with their abdominals and gluteals to see if they could change the spine, and it really didn't change very much. However, if we stood them up with their knees straight and asked them to do a pelvic tilt, we got reduction in every level of the intersegmental angle. Fortunately, we had a disc. I had put in my proposal to the board that if there was an asymptomatic disc on all these asymptomatic patients, that I thought the disc would reduce in size or go away. And so we had in the recumbent, you can see a small disc there, but standing, the disc protruded more. In 20 degrees of pronation, it still protruded, but as soon as we supinated them 20 degrees, the disc went away. I wanted to see if the core would have an effect on the disc, so we had them stand up with their knees straight, did a pelvic tilt, and it was still there. However, when we supinated the foot in 20 degrees, the disc went away. And that is what I had predicted before we reviewed these films. The cause for this is because when we pronate, we internally rotate the femur. The femur, these muscles of the adductors are attached behind the femur, and they run from the knee to the hip. They attach mostly in the front. So when you internally rotate, you actually tighten it. You actually tighten the adductors, and this pulls the pelvis into an anterior position. And also the extension of the leg adds to this. You can see that it'll make the muscles tighter. The iliopsoas, of course, attaches in the posterior greater trochanter area and has the same mechanical effect as the adductors. And then also the rectus femoris plays a role in pulling the pelvis forward. But when you pull the pelvis forward, you close the foramen laterally and cause impingement. However, when you supinate the foot, there's several things that happen quite dramatically. Number one is it frees the pelvis to do a posterior pelvic tilt. But what we'll show you in a little bit is the muscles of the core cannot engage as long as they're in a pronated position. So the muscles engage, we get some relief in a posterior direction. It opens up the foramen and allows for less impingement of the nerves that feed the lower extremity. This is a video showing when you get an anterior pelvic tilt, you have to compensate with, and this causes a narrowing of the foramen. This is a film I like to show because we want to evaluate these patients in mid-stance position. In mid-stance position, the knee is straight, the leg's internally rotating. So we just basically hold the patient in their standing position, which is usually pronated, and then we ask them to do the core. And because the core or the abdominal and gluteal muscles are not strong enough to overcome the adductors. The patient literally falls backwards when they try to do a pelvic tilt. Most people can only do a pelvic tilt by bending the knees because they've relaxed the adductors and the iliopsoas and rectus femoris. So I wanted to look on how this affected the upper extremity. For 4 decades, we've known that if you pronate, the trapezius and deltoid muscles are weak. And so I felt that if we could demonstrate if the core doesn't work, your gluteals don't work, your back muscles don't work. So I met Dr. Stevens and his son Aaron, and they were doing work with the surface EMGs, and working with the mouth and the bite plate. So I got together with them, and Aaron called it the Newell team. So we really have had a great relationship. But we put superficial electrodes on the gluteal muscle and the abdominal muscle. Below, we kept the knee straight and asked him to do a core, and you can see that the gluteals fired about 55 microvolts. However, when you supinated them 20 degrees, it jumped to 80 microvolts. If you look at the abdominals, it was 40 microvolts, but it jumped tremendously to over almost 90 microvolts. So I wanted to see if this affected all the way to the trapezius and deltoid. So I tried to connect this, the dots here. So we used the surface EMGs on these lower back muscles and the lower part of the trapezius. The trapezius and the abdominal gluteal muscles are large muscles and have a lot of electrical outlet. But however, the lower and the lower part of the trapezius is not a lot of muscle surface to get a lot of electrodes. But you'll see the same thing happens here. The abdominal muscle, which is in the orange, was less than 40 microvolts. However, when we allowed them to use the core and 20 degrees of varus, it jumped to over 90 microvolts. The same dramatic thing happens with the gluteals, 55 probably to close to just under 90. We got some movement of the lower back in the direction of more activity, and the lower part of the trapezius actually tripled in its activity. So I thought, if the foot has this much power in relationship to the muscles, what if we combined the aligning of the jaw and mouth? Would this contribute to even more to the strength of especially the upper neck area? So Dr. Stevens and his son made these mouthpieces. They have a way of making a neutral bite and made a science of it. And so I worked on the feet and he worked on the mouth. And this is a result. We tested the deltoid and the MRI, and you can see they were standing and pronating. The deltoid on the left had 40 microvolts, but when we supinated them 20 degrees, it went to 55. The trapezius was 44 microvolts, but as soon as we supinated them and asked them to resist against the trapezius muscle, it went to 101 microvolts. We added the bite plate to this, and it jumped from 55 microvolts in supination to 63 microvolts. And with the trapezius, it went to 101 microvolts. And with the bite plate, it went to 108 microvolts. One of the great things about this is it also increased the duration of the time the muscle could hold. So there's over 1,000 milliseconds with no orthotic, over 3,000 milliseconds with orthotics, and 4,000 milliseconds with an orthotic and about bite plate. This leads to really what we're going to do. We're going to do this research or another pilot study on the disc. We're going to look at the muscles around the jaw. As you can see, the trapezius goes clear up to the neck, and next to that is the sternocleidomastoid. So we're interested to see if it changes all the muscles around the neck, because it's very important for protecting the cervical area in sports. You want to protect the neck. It also is very functional in sports, as I think it helps in performance. So we're going to look at that with the dentist and try to record the EMGs. We're looking at head position now. This is 19 patients, and when you supinate the foot, the head goes back average almost a half inch. What Dr. Stevens has done, though, is if you look at this man on the left, you'll see from below the belt, he doesn't change. He puts a balanced bite plate in, and the head goes back about an inch. They have a way of measuring the neutral position of the head by the electrical activity of the muscle. They use the temporalis muscle. If it's very, very active, they know the head is in a bad position, and the more it's in rest, the less firing. So I made orthotics on this patient, and without orthotics and without a bite plate on the right side, we had over 11 microvolts of activity. When we put the orthotics in, it went down to 7 microvolts on the right side. We put the bite plate and the orthotic in, and it went down to the bite plate only, and it went to almost 5 microvolts. And if you combine the two, the right temporalis was 3 microvolts, and the left temporalis was down to 2 microvolts. So this leads us to the lower extremity. We sort of covered from the waist up now what effect we have on the back. But this is an area that I really think is clinical. We've tried to show that with increased lordosis, you get narrowing, and we believe that you get soft tissue impingement, capsular impingement. It could be a disc, it could be exostosis. When you close that down, it actually impinges on the nerve, and you get a functional stenosis and a functional impingement of the nerve. As we've tried to show, the functional stenosis does create weakness, and then supination reverses this. Supination opens up the foramen so the nerve can fire, and you get your strength back quite quickly. I can tell you that after measuring hundreds and hundreds of low back muscles, everyone that has a low back has a 95% chance of having weakness. They almost always do. It could be a one on one side or one on the other from S1 to L2, but they will have weakness. And the S1s demonstrate it with the perineals, the lateral hamstrings, the gluteus maximus, and the gastroc. And L5, which is the most common area we see in the low back, is the extensors, medial hamstrings, and the gluteus medius. And we found in our retrospective studies that the medial hamstrings actually is the weakest of all these when we test them. The functional stenosis of L4 is demonstrated with the anterior tibial. These two don't necessarily go together, but if there's weakness of L4 and L3, the quads are weak. And L2 and L3 are the iliopsoas. This is what we've done here. This is a study of retrospective study of 8, but it's really typical of what we see in my practice. We took the amount of weakness of the perineals and we averaged them out, and they were about 3.5 over 5 in strength. However, 6 weeks later, which is the green, they actually had full strength. And you can see that in 6 weeks in an orthotic, all these muscles recover, and almost all of them get full strength. The anterior tibial was strong in these 8 groups, both with and without an orthotic. Same thing with the lateral hamstring, the medial hamstring. The quads were fully strong, both with and without an orthotic. The iliopsoas was the weakest, but it recovered and had full strength. And the same thing with the gluteus maximus and gluteus medius. Pronation, so I tried to develop a test that we could do in the office. I called it the S. Newell pelvic tilt test because I didn't want Dr. Dave Newell to get the credit. And I called it this because I wanted podiatry to make an impact on the back, and I wanted to sort of document it, that we have a great place to play. So the goal of the orthotic is to take a lady like this that pronates. You can see she's knock-kneed. The space between her knees are on the left where she's pronated, almost touching. The heels are everted, and the knee is internally rotated. If we take this person and supinate them, we actually line the whole leg up. We derotate the leg, which untightens the adductors, the iliopsoas and the rectus femoris, and the knees in a good anatomical position. And so what we've done here, let's see if I can go back here. What we're going to do here now is we're going to do a test of the medial hamstrings, which is the L5, and then I'm going to ask this patient to do a core, which is actually tightening your gluteals and your abdominal areas up, and then retesting to see if this person is stronger. So here is the test we do. This is a person that's about a 3/5 in relationship to strength. She's really weak. And then I'll ask her to do the core, and you can see, I'll see her pointing on the tongue. Watch her tighten her belly, tighten her gluteals, and I can't hardly move it. And watch her rebound here. She's she's got full strength on that. This is this is the same patient. We're doing the gluteus medius, and you can see that I can push this down. I ask her to do the core here, and here she is. I'm trying to sit on it, and she can hold me up. Dramatic difference. This is night and day strength difference, by the way. This is a case report. This patient is a 37-year-old. She blew out her disc when she was doing crunches, and she had bladder weakness and muscle weakness. So she came here, and they did a discectomy, and it was very successful. Everything returned to normal. 2 years later, she had the same sort of issue. They did a microdiscectomy, and it was very successful. A year later, she had the same problem, so the surgeon said, let's fuse S1 and L5. I saw her 3 months later, and she had a non-union. She had major weakness and major ataxia. So here she is. You can see I'm doing extensive. I'm asking her to, she just has 1 or 2. I called it 2, but really this is a 1 or almost a 0. Then I asked her to do the core, and she could recruit that whole extensor hallucis longus. This is her with the quadriceps. She's weak in the quadriceps. And again, I'll ask her to do the core, and you'll see I'll touch her belly, say, do the core. Now she can keep that baby up at 90, and when I rebound, you can see how strong she is. So that was encouraging because we knew these muscles would come back. This is her 5 weeks in orthotics. The gluteus maximus and the gluteus medius, she could not keep her leg up on both right and left side. This is 6 weeks later in an orthotic, and this is doing the core right here, and she can keep that leg off the table. Just amazing, because I thought she had S1 damage, and the people that were reading the MRI thought that she might have damage from her disc, and so we were really fortunate. We could tell by the testing that this muscle would return. This is her. The quadriceps and the iliopsoas here are on the left side, and she had an arthritic left hip, so these muscles did not respond to testing very well or to core testing. This is the core. You can see, we could see that the muscles would recover fully on the anterior tibial and the extensor hallucis longus. But the other ones were questionable, and you can see the gluteus maximus could not fire either with the core or trying to do it without the core. This is 5 weeks in an orthotic with a pelvic tilt. You could see that almost all the muscles were improved dramatically, which shocked me, was the gluteus maximus was really strong. And again, I showed you on this patient that when we did the core test, she went to a full 5/5. So we're sure that when her back pain is better and her hip pain is better, this muscle will fully recover. So a conclusion is functional stenosis can be evaluated by the pelvic tilt test, and it's helpful to determine weakness and at what level, and it's also helpful to determine if this is a good candidate for orthotics. Functional stenosis usually can be reversed very quickly, within actually 4 to 6 weeks in most cases, because the pressure is just taken off the nerve. These are general conclusions. Low back pain can greatly be benefited by proper alignment. The bite alignment and lower extremity alignment work together to allow for more strength. The bite and lower extremity alignment are synergistic with head position. And for the athlete, proper alignment will allow for injury prevention, injury recovery, and increased performance. Thank you very much.